thank you for the opportunity to share our initial clinical experience of applying a Topcon-developed algorithm for automated volumetric CVI analysis. Corodovascularity Index has been described several years ago. It is a concept that segments the structural OCT using the Brooks membrane and choroidal scleral interface as boundaries and binarizing the content of the choroid into luminal versus stromal areas as a ratio to the total choroidal area. Previously, we utilized single subfoveal OCT scans in patients with exudative AMD and described that study eyes had lower CVI compared to fellow eyes. In longitudinal follow-up studies, we also described a significant reduction in choroidal thickness subfoveally, where CVI at the subfoveal area was largely unchanged. What is new is now the ability to automatically delineate CSI as well as Brooks membrane, which saves a lot of time, and therefore we can generate a automated volumetric choroidal thickness map throughout the macular area and appreciate regional variation with much more sophisticated appreciation. We can then binarize each and every single scan and also generate a CVI map, as you can see here. In our pilot study, we specifically analyzed the central 4 squares as described here as the macular CVI. We applied this beta algorithm to a cohort of treatment-naive PCVIs undergoing Eylea therapy over 12 months, and the scan acquisition used was the standard 6x6 macular OCT, in which we just used the structural scans, which were averaged 4 times. We correlated the baseline subfoveal choroidal thickness and macular CVI, as well as evaluated longitudinal changes in these 2 parameters. At baseline, as you can see here, the 2 values, choroidal thickness in the x-axis and CVI in the y-axis, correlated quite well with each other. However, if you look at the scale, you can appreciate that there is a much wider range in choroidal thickness compared to CVI. Here are 2 examples of an eye with thin choroid and low CVI in the left, and a thick choroid and higher CVI on the right-hand side. This range of CVI is largely in keeping with what has been described using the Zeiss swab source OCT. In this paper, they described a range of 55 to 68% in normal individuals. In terms of longitudinal changes, I have highlighted the no change line in choroidal thickness in the y-axis in red here. And you can see that over 12 months, most eyes demonstrated a reduction in choroidal thickness in the region about 20 to 30%. In contrast, for CVI, most eyes were hovering around the no change line with very little range of change, going from 96% to 102%. Here is one example showing you baseline month 3 and month 12 scans, and we can appreciate there is significant reduction in both thickness and Corodovascularity Index. And even by eyeballing, we realize that at month 12, the choroid looks a lot less dark compared to baseline. There's another example, again showing significant reduction in the thickness. However, the CVI change was less marked in this eye. A couple of pitfalls to mention for this algorithm to be successful. A lot of blood and large PED is going to be a problem because of signal loss inside the choroid, which affects the accuracy of segmentation. And in eyes with very thick choroid, there can be suprachoroidal effusion, which can also make the delineation of CSI tricky. So in summary, we found that there is a wide range of choroidal thickness but small excursion of CVI. And with treatment, again, we found that significant thinning was demonstrated, but CVI changes were very small. This is similar to what we found previously using a single subfoveal scan. The study demonstrated the feasibility of using this automated algorithm to a standard OCTA acquisition, and the volumetric assessment allows us to appreciate regional changes much more sophisticatedly than we could previously using a single subfoveal scan. So thank you for the opportunity to share.